Hi everybody, welcome back to the Code Blue Classroom. My name is Ashley and today we are going to be chatting about lactate levels. So let's dive right in. The content of the Code Blue Classroom is intended for educational and informational purposes only. While I am a licensed nurse and nurse educator, I am not providing medical advice, diagnosis, or treatment on this platform. Always follow your facility's policies, clinical judgment, and current evidence-based guidelines. The information shared here is not a substitute for professional training, institutional protocols, or medical direction. By watching and engaging with this content, you acknowledge that you are responsible for your own clinical decisions and professional practice. No provider-patient or educator-student relationship is established. Any views expressed are my own and do not reflect those of any employer or institution. If you have a medical emergency, seek immediate help from a qualified healthcare provider or call emergency services. What is lactate exactly? At the basic root, lactate is the byproduct of anaerobic metabolism from insufficient oxygen delivery. Lactate dehydrogenase is an enzyme used during glycolysis. Glucose is made into pyruvate, which is then metabolized into adenosine triphosphate, or ATP, if you remember that back from the anatomy and physiology days. In states where oxygen is limited or even absent, LDH, lactate dehydrogenase, catalyzes the conversion of pyruvate into lactate through an anaerobic pathway. So what the heck does all of that jargon even mean? Lactate is a product of the lactate dehydrogenase enzyme during states of high glycolysis, that breaking down of glucose for energy without oxygen. So this would be like during exercise, muscle injury, tissue hypoxia, or sepsis. Please know this is not an all-encompassing list of conditions, so don't take that as a full list. There are many things that can cause this to happen. Lactate is produced in all the tissues of the body, but it's most abundant in red blood cells, the brain, and muscles. Hence why when we have a difficult exercise session or don't properly train, we can feel that buildup of lactate in our muscles, causing like pain and soreness. So to reiterate, lactate is the byproduct of anaerobic metabolism from insufficient oxygen delivery. So what's our normal value here? 0.5 to 2 millimoles per liter. Please reference your hospital lab for normal values and ranges because it can vary from institution, but this is just a generic range that's provided by most of the literature. In normal circumstances, the cells utilize oxygen, which keeps lactate levels low. We can see slight increases in lactate levels with exercise, but they quickly return to normal during rest periods. So think about those individuals who choose to do obstacle course races without proper training and preparation. What happens to these folks? A buildup of lactate occurs from anaerobic metabolism. With enough anaerobic metabolism, muscles can break down, which results in an increase in serum creatinine kinase, or CK levels. On the mild end, they're sore and cramping and recover with hydration and active recovery instead of just complete and total rest. On the opposite end of the spectrum, we have people who are competing in these extreme races, potentially in adverse weather conditions, and the result is this large buildup of lactate and CK. In severe enough cases, that amount of anaerobic metabolism can actually result in the breakdown of the muscles and cause rhabdomyolysis. So back to lactate. Elevated lactate signifies a global perfusion problem. This is why we utilize it as a rise marker, and we can use it as a resuscitation target. That is so important for you to understand. It's a rise marker and a resuscitation target. We'll get into this a little more in a second. Studies show that increased lactate levels are strongly associated with increased mortality in critically ill patients. Specifically, levels greater than 4 millimoles per liter have almost double the odds of hospital mortality compared to patients with normal lactate levels. Armed with this information, we as the nurses can have an impact on obtaining this lab work, caring for these patients, and potentially reducing their mortality. Who are we drawing these levels on anyway? This list is expansive, however not all-inclusive. Again, I just want to reiterate that lactate can be helpful to trend, but also functions to serve as a resuscitation target. So we're going to be doing these these levels on sepsis patients. Other shock states such as hemorrhagic, cardiogenic, cardiac arrest patients, postpartum hemorrhage, severe respiratory failure, anemia, metabolic crises like DKA, or toxic ingestions. Routine monitoring / trending of critical patients, post-surgical intervention, and multi-organ dysfunction patients. You'll see we'll trend those values for them because we want to know, are they improving or are they getting worse? Is our treatment doing what we expect it to be doing? So, for example, in patients in shock states who've been fluid resuscitated, a lactate level that is decreasing after 3 hours would be an indicator of that our resuscitation efforts are actually working. Conversely, if the patient has a worsening lactate level despite treatment measures, then the target isn't being achieved and an alternative measure may be needed to be considered. However, despite lactate being a helpful indicator, it is not specific for single etiologies and requires a bigger overall clinical picture for interpretation of results. It's not a disease-specific marker, so just know that when we do a lactate level, this isn't saying that we're going to diagnose someone specifically with sepsis. We really need to be looking at the bigger picture and interpreting these results. So let's talk about some quick tips for our lab draw. So there's a lot of things that can go wrong with drawing a lactate. This isn't like some of our other blood work, which is relatively simple to acquire. We can collect samples from arterial or venous blood samples. We get it through a peripheral draw. We can do it with initial IV insertions, central lines, ports, and arterial lines. We do want to draw lactate quickly, so prolonged clamping or strenuous fist pumping to pump up the veins during a draw can actually result in inaccurate lab values. You'll also see, I also want to avoid prolonged tourniquet times. So keeping a tourniquet on for an extended period of time will actually also increase that lactate level, which could improperly paint a picture that we don't want our providers to see. So it'll give us a really inaccurate picture. We want to quickly place the specimen on ice or run the test immediately. Some places actually have point-of-care lactate testing, which is a rapid and helpful tool in rapidly identifying patients who are critically ill or have the potential to deteriorate quickly. Some studies indicate that utilizing lactate in the triage setting dramatically improve recognition of severe sepsis, sometimes more than other tools. We triage our patients and we assign them a triage number. And this number sometimes not always paints a picture of how really sick our patients are, right? Vital sign wise, they're doing okay right now. But then once we get lab work back and we see white counts and we see these lactate levels, we realize our patients are actually a lot more sick than what their vital signs are indicating. So for ERs that have longer wait times or patients sitting in the waiting room, if you can get point of care testing or get some blood work done immediately, these values might actually bump up their acuity and get them back and seen a little bit faster, perhaps than someone who has a normal value. So how are we interpreting these results? So again, just as a refresher, our generically accepted normal value is 0.5 to 2.2 millimoles per liter. A mild elevation, 2 to 4, considers some possible hypoperfusion. Again, we always want to correlate clinically. And then critical values would actually be greater than that, 4 millimoles per liter. This is indicative of lactic acidosis and should be treated as an emergency in the correct context. Patients, medical conditions such as metformin, seizures, and liver failure can all actually raise lactate levels, so just something to consider. Remember, shock can exist even with normal lactate values less than 2 millimoles per liter. So again, this is not diagnostic. Just because there are normal values doesn't mean a patient isn't in a certain disease state or process. Avoid being an alarmist. Many facilities and studies indicate that it's really best to trend the lactates, which helps to determine what direction the patient's care needs to go. Lactate, sepsis, and shock. Oh my. So there's some really interesting targets on here. So if you've never heard of the Surviving Sepsis campaign, I highly suggest you check it out. There's a lot of really great information that they share about sepsis and current treatment guidelines and like our nursing targets and goals. So the Surviving Sepsis campaign has made a lactate a core sepsis marker. Specifically, it's helpful for cryptic shock where blood pressure is normal but lactate levels are high. So again, this goes back to our vital signs stable patient. However, their blood work is painting a totally different picture. These patients would actually fall by the wayside if we didn't see them and do lab work, which is often why patients who feel okay and then come in super, super sick, it's because they may not have these vital sign changes that are making them feel poorly. So there are some guidelines. Some protocols focus on utilizing lactate to guide resuscitation. So as a guideline target, you do your first lactate, you might start treatment, or some people even withhold treatment until you get that lactate to determine what the plan of action is going to be. Again, follow your facility's policies and procedures. In shock states, such as hemorrhagic or cardiogenic shock, lactate does rise. We need to correct the volume problem or improve the perfusion, which typically will lower the lactate, whereas failure to correct lactate means the shock state remains. So do you want the morbid truth? Lactate levels and mortality have a proportional relationship. The higher the level, the higher the mortality. One study found a 28% mortality for patients with a lactate level greater than or equal to 4. Even without hypotension, a lactate level above 4 is associated with poor prognosis. Remember, it's a prognostic tool, not just a number. So where the heck do we as nurses fit into all of this? Since this is a prognostic tool and aids in the diagnosis of various conditions, what is our role in lactate levels beyond simply just drawing the lab work? So notify. Communication is the crux of nursing. It's our job to notify the provider of abnormal results, as prompt adjustments to treatment plans can improve patient outcomes and reduce morbidity and mortality. I can't stress that enough. So next we anticipate. The more experienced you are or become in nursing, you come to know what to anticipate the providers to order. But if we understand the process and the policies and procedures and treatment guidelines, we can provide faster and better care for our patients. Where do we fall as nurses? What is our job? We need to be doing our initial lactate measurement. We should be doing serial measurements approximately every 2 to 6 hours as ordered by the provider. And then we really want to work on restoring tissue perfusion. So this usually is through IV fluids. We can do cause-specific interventions, so antibiotics in sepsis, insulin for diabetic emergencies, discontinuation of drugs that might be causing a metabolic acidosis. And remember, this is a state of anaerobic metabolism, so we really want to improve oxygen delivery, optimize that oxygenation. The last step is going to be to recheck. So our job every 2 to 6 hours as ordered, we're going to be rechecking those lactate levels. We then, in a circular fashion, go back to the notify. We're going to be notifying our provider so that way they can assess whether or not their treatments are having an optimum effect for our patients. So what are our key takeaways? Remember, timely and proper collection are integral in getting accurate lactate levels. What are our normal values? 0.5 to 2 millimoles per liter. Greater than 4 millimoles per liter is associated with greater mortality. And we want to correlate our value with that clinical picture. Lactate is not disease specific. It is a global perfusion marker. So our role as nursing, use the value to guide urgency, escalate care, trend our values, and communicate to our providers. So that's a wrap on lactate levels. Leave me a comment down below with the highest lactate level you've ever seen. Please give this video a like, subscribe to the Code Blue Classroom so you get notified when the latest video drops, and as always, knowledge is your best code card, stock it well. See you next time, everybody.